Good morning again, and thanks for your attention. My name's Glenn Taylor. I'm the Chief Executive of the Nursing and Midwifery Health Program, and I'd like to formally welcome you to today's event. It's been a long time in the making. We're very excited about what's going to unfold today, and we're very excited to have you here, our fellow colleagues. Before I start, I'd like to take the opportunity to acknowledge the traditional owners and custodians of the Wurundjeri people of the Kulin Nation, upon whose land we meet and whose cultures we celebrate as among the oldest continuing cultures in human history. I'd like to just make mention and welcome two of our guests this morning. Emeritus Professor Judith Parker, who's the chair of our organisation, and Mr. Greg Miller, who is a psychiatric nurse and also chair of the Victorian Board of the Nurses Board, the National Nurses Board. Lisa Fitzpatrick, who's the Secretary of the Australian Nursing Federation Victorian branch, will be joining us shortly, as will the Federal Minister for Health, the Honourable Tanya Plibersek. I'd also like to extend a warm welcome to our directors. Thank you for your attendance. To our invited guests, and as I said, especially to you. You're the reason that we're here today. You're the reason that this organisation was started in 2006, and you're the reason that we and my small band of colleagues continue to work really hard to ensure that your health and your wellness is paramount and that you can continue to do the work that you do so well. I'll just refer you to the screens behind me for the announcements. If there's anything that you have in particular needs, you can see the registration desk or ask one of the staff. It's kind of interesting today that you may be interested that as of yesterday, we registered our 1005th episode of Care. Now, recording our participants as episodes of Care or episodes is a necessary practice for us. This assists our data analysis and record keeping. However, I'm conscious that when we refer to our participants as episodes, we do risk depersonalising them. So, today, I'd like to take this opportunity to personalise or put a face to these important people. So what do they all have in common? Well, they're all nurses, midwives and students, for one, and they're all part of our profession. But in addition to that, they're all people, they're all human beings, they're all carers, they're all givers, they're all doers. Many have dedicated decades of their profession and to their patients, clients and residents. These people are mothers and fathers, sons and daughters, brothers and sisters. They're partners, friends and community members. A qualification in nursing or midwifery does not protect any of us from illness or impairment. The illnesses or impairments we specialise in at the NMHP are often sensitive in nature. These are substance use challenges and mental health concerns. These are very difficult issues for many of us to discuss openly and with confidence, given the fear, the shame and the guilt that's associated with being a nurse or a midwife who's experiencing these concerns. None of us are immune to these conditions, and all of us are susceptible. Myself and my colleagues, Carolyn and Natalie, feel privileged to be in the position where we can support our own. Privileged to sit with a fellow nurse, to provide an ear, display understanding and compassion, support and guidance. At times we're exposed to people in the depths of despair, fellow nurses who have regularly sacrificed their personal lives, their families, their relationships and all too often their own health in order to support and promote the health of those in need in our society. We provide assessment, case management, referral and support. At times it's a brief intervention, at other times it's a much more formed and stronger and more developed professional relationship. The NMHP has been dedicated to this work since 2006. We've managed to help hundreds of colleagues regain and maintain their health. We've helped those who were struggling to survive to now thrive. These claims have been tested and formally researched, and with that, our numerous achievements documented. Unfortunately, we're facing a significant dilemma. Many of you would be aware that our funding, which equates to less than $6 per year per Victorian nurse, is scheduled to end in June of next year. I know many of you have been directly involved with a campaign that the ANF Vic branch has commenced on behalf of Victorian nurses and midwives to retain our service, and I thank you for your support. I'm heartened by the support offered to the Nursing and Midwifery Health program each day, and I trust we will find a solution to this dilemma through all the work we and others are doing behind the scenes. Please take the opportunity to share this message to those in our profession at every opportunity. None of us knows what's around the corner. Our good health is essential to a good quality of life. It is critical to our ability to function at work, but I'd argue it's more important for us to have this gift outside of work. We believe the NMHP is now an established and fundamental part of the Victorian nursing landscape and something we must fight to retain for our own sakes, for the sakes of our families, friends and communities, and for the sake of those in need of our care each day, our patients, clients and residents. I thank you for accepting the invitation to be here today, and it would appear by the numbers that have again turned up, it's struck a chord with the nursing and midwifery community. And today's theme of wellness is something that is as important to you as it is to us as the NMHP. I would like to acknowledge and thank the ANF Vic branch for its wonderful support in organising today, with special thanks to Lisa Fitzpatrick, Bobby Kurikos and his team. This would not have been possible without their work. In preparing the program, I've been struck by the goodwill and generosity which has been displayed by so many we've been approached by and who we've approached. This extends to our speakers, our panellists, leaders in our industry in Victoria, and most importantly you, our delegates. Many of you have generously and bravely shared your health challenges with us through time, and I hope that you can all take away something that will feed your soul and make you smile. Have a great day, and I'd like to welcome Lisa Fitzpatrick to the stage. Thank you very much. Just one quick announcement. A number of people have managed to slip through without registering. Can you please, at the morning tea break, register? You'll get your lanyard, your booklet, and most importantly, you'll be able to pick up your certificate later. Thank you.
Thank you. Thank you very much, Glenn. And can I also acknowledge the traditional owners of the land on which we are meeting, and I pay my respect to their elders, both past and present. The Nursing and Midwifery Health Program of Victoria was an initiative of the Australian Nursing Federation Victorian branch, together with the then Nursing Board of Victoria, and I particularly want to acknowledge the CEO of that board at that time, Ms Louise Milne-Roach, who so passionately supported and had great drive to make the program happen. As Glenn has indicated, it's a critical part of the nursing and midwifery landscape in Victoria, and it is an extraordinary program that plays a very important role in the lives of nurses and midwives in this state, as well as students of nursing and midwifery. Critically, the program has been independently researched, and the paper released by Dr. Bridget Hamilton and Dr. Rachel Duncan in December of last year made very important findings that in its short span of 5 years, that what it had achieved was quite remarkable. The report showed that the program works with really 90% of its referrals being self-referrals and only the 10% being referrals from the regulatory authority, but also from employers. 60% of those who have completed their care through the program have been able to be maintained and retained and returned to work and have been kept in our important nursing and midwifery profession. The program has already gained international recognition. It has strong and transparent governance. Its processes are overseen by a dedicated board led by Professor Judy Parker and other directors, and also our CEO of the program, Mr. Glenn Taylor, a mental health nurse himself, hardworking and very committed to ensuring that the program continues, that it expands, and we now see that it has expanded into regional Victoria so that there is a presence in Bendigo, in Ballarat, in Shepparton, in Traralgon and now Geelong. And importantly, the program runs on the smell of an oily rag, and I'm sure Glenn would like to have some additional funding, but you will be aware that we are at a critical stage in relation to securing the ongoing funding of the program. At this stage, around $5.50 of your and our registration fees are dedicated to ensuring the success and the ongoing work of the program, but we have only secured that funding from the Nursing and Midwifery Board of Australia for the remainder of the 2013-14 financial year. We will, of course, the program is dear to our hearts at the ANF, and it's not just dear to our hearts, but it's also part of our core business in the way we can support nurses whilst being totally independent from the ANF, being independent from government, being independent from employers. But seeing the ongoing work of the program is absolutely critical, not just to the ANF Victorian branch, but we know to thousands of nurses and midwives across our state. And one way to help secure funding is to raise the profile of the program. And so today we have invited the Federal Health Minister, Tanya Plibersek, to open the conference. Tanya has been the Federal Health Minister since December 2011, but prior to that has held many important posts within the federal government, both in government and in opposition, first entering Parliament in 1998. She's got a strong background in relation to, I think, social issues in particular, as well as her interest in women's issues and in women's health, and in her capacity as Federal Health Minister as a broader health system here in Australia. And it's critical that she is aware, and we have made her aware of the importance of the program and how the program is in jeopardy. And I'm very pleased to welcome Tanya. She's not just obviously very busy with her portfolio, but she's a reasonably young mum with 3 wonderful children, and has got up, I think, at 5 o'clock this morning and left Sydney so that she can be here with us today. I welcome you, Tanya. It's great to have you here in Victoria, and thank you for coming to open the program. I didn't do it justice in the bio.
Thank you. It's a great pleasure to be here with you this morning. And the only thing I take issue with is reasonably young mum. Come on now, no one wants to hear that at the beginning of the day. I want to start by paying tribute to the traditional owners of the land that we meet on today, pay my respects to their elders past and present. I also want to say how wonderful it is to be amongst so many friends, to be greeted by Lisa Fitzpatrick, the Secretary of the Australian Nursing Federation Victorian Branch. I believe Yvonne Chaperon is here, the Assistant Federal Secretary of the Australian Nursing Federation. I saw Pip outside, Pip Carew, the Assistant Secretary of the ANF Victorian Branch. Greg Miller, the Chair of the Victorian Board of the Nursing and Midwifery Board of Australia. Judy Parker, of course, the Board Chair of the Nursing and Midwifery Health Program, and of course Glenn Taylor, the CEO of the Nursing and Midwifery Health Program. Look, one of the most wonderful things about being Health Minister is the opportunity I have to visit health facilities around the country and to speak to the staff there who are on the front line of delivering health services to Australian patients. Some of the best and most insightful conversations I have, of course, are with the nurses and midwives who are delivering the bulk of services to Australian patients, not just in hospitals, but more and more also in community settings. Indeed, it's not possible to overstate the importance of your profession, the 340,000 Australian nurses who deliver such critical health services around Australia. We are absolutely committed as a government to recognising the importance of the work that you do and supporting you in that important work. And that includes our support not just for nurses in acute care settings, as I said, but in aged care, practice nursing, rural nurse locums, as well as, of course, our role as a federal government in supporting thousands of nursing scholarships in recent years. I'm very pleased to say that we've been successful in boosting the number of graduates and students completing their initial registrations as nurses or midwives between 2007 and 2011. This number's grown by more than 2,000 a year, so that we had 10,000 graduates in 2011, an increase of around 25%. Now, I know that graduating nurses is not the end of the story, but that transition to practice and then a whole career progression is important to attract and retain people into the nursing profession. The other thing that I believe very strongly that we need to look at is how we retain and attract back nurses who've left the nursing profession. The role of nurses and midwives is to provide the very best of clinical care, and you do that more and more as part of teams collaborating to care for patients, with the patient at the centre of the team and the health professionals working around that patient to ensure that they get the best possible care. Nurses, that means, are working more and more at a higher and more complex level of responsibility, diagnosing and treating common illnesses, prescribing and dispensing medicines, and also performing procedures. In fact, we see that because nurses are working at this higher and expanded scope of practice, that many of the rewards of the work, of course, are increasing, but the pressures of the job are also increasing. Anyone who works in a field that involves so much giving to other people will inevitably sometimes feel the pressure of that requirement. You'd be all very familiar in your professional lives with the patients that you observe. What happens if stress goes untreated and undealt with for a long period of time? It means that even the strongest professionals, and I know that many of you see yourselves as very, and indeed are, tough and strong professionals, but you can't keep giving without looking after yourselves either. And we see when stress goes ignored for too long, even the strongest people succumb to absenteeism and sometimes illness. It has an effect on us as individuals, but also an effect on the people around us, in particular our families and the quality of our own relationships. It can result in lower job satisfaction, impact on the quality of care that we give, create organisational inefficiency and higher staff turnover, and ultimately increase the cost of care. I looked at some research by the Carter Centre in America, because you sometimes hear that nurses or doctors or other health professionals have higher rates of work-related issues like drug and alcohol consumption. This research from the Carter Centre said that, in fact, drug and alcohol consumption were no higher in the nursing profession than in other professions generally. But what they did observe was a higher use of other medicines, so non-prescribed medications. Just as an example of some things, one of the things that might happen if you have people working under a great deal of pressure over a long period without the sort of support that we're talking about today. That report also observed that there were aspects of the nursing workplace that put nurses at greater risk of substance abuse because of the constant care that you're required to give, the fact that you're always putting your patients first. While none of these issues are unique to nursing, of course we see pressures in other areas of work. We see workplaces where that pressure leads to potential drug and alcohol misuse or stress-related mental health issues. I think one of the unique aspects of nursing is that your whole professional focus is on caring for other people. So who cares for the carers? This brings me to the Nursing and Midwifery Health Program, which works to underpin a healthier and safer nursing and midwifery workforce. I want to pay particular tribute today to the work that Judy Parker and Glenn Taylor have done, and of course the others that have worked on the board as well, in building a program that has so much support and such good results, so much loyalty indeed from the Victorian nurses in particular. The program does its work by supporting nurses and midwives who have drug and alcohol problems or mental health issues to make sure that we get in early to support those people, to care for the carers. The Nursing and Midwifery Health Program also supports managers and organisations to deal with those issues in the workplace, to make sure that our workplaces are safe, for the people who work in them. The program's based on sound and strong guiding philosophy, and part of what makes it work so well is that it is a nurse-led service designed by nurses and midwives for nurses and midwives. It's very much a we take care of our own program based on mutual understanding, respect and care. This certainly removes the stigma that's often attached to asking for help. The program takes a modern, prevention-based early intervention and health promotion approach, and that pays dividends obviously for the individuals who benefit, but also of course for our health system as a whole. It's a testament to the program that it's delivered so successfully both to individuals and in group-based environments as well. An overwhelming majority of the people who've reached out for support have been helped to change their behaviour, improve their own health, remain at or return to work, or plan to return to work in nursing and midwifery. And this is a slight aside that I want to raise with you today. Today I'm releasing publicly a report that I commissioned from Jennifer Mason about workforce programs that are run by the Commonwealth Government. We spend an enormous amount of money on training and attracting people from overseas to work in the Australian health workforce. We're always training new nurses. I told you some of the numbers earlier, but one of the areas that has been of real concern to me, and one of the reasons I asked Jennifer Mason to undertake this review, is what do we do about retention and what do we do about people who've left and getting them back into the workforce? And I think nursing is one of the clearest examples of the importance of having thoughtful retention policies and reattachment policies, not just training new people all the time. The Mason Review, and you'll be able to have a look at it yourselves in as much detail as you like. I'll release the whole report, but the Mason report does look very much at those issues of education, of career progression, making sure that we continue to keep people interested and engaged, that we give career pathways that are expanding and that offer people a long career in nursing, that we don't suck them dry in the first few years of their work and then see them leave, lose those skills and lose that enthusiasm for nursing from our system. So the work about career progression is very important in the Mason Review. Much more work on expanded scope of practice. She's also recommending and higher level of practice as well to retain people in nursing. One of the other things that she mentions that I think is very important is the management culture that nurses deal with. I'd like you to read the review for yourselves, but she does recommend that we need to look at better training and equipping nursing managers to make sure that they are better supporting their workers, to make sure that they are providing a workplace that is a place where people can work long term without being burnt out. I'd like to finish up by thanking the Nursing and Midwifery Health Program for its very important work, and I want to conclude by saying I have been convinced by the arguments that have been made by Lisa Fitzpatrick and the leadership of the Victorian ANF, by the people who have participated in this program, by the people who have raised with me the valuable resource that it is. I've been convinced that it is a very worthwhile program, and I have put onto the agenda for the next meeting with the State and Territory Health Ministers a proposal that health ministers would continue to fund this program and indeed that we expand it to a national program. So I hope that with this commitment that nurses and midwives, not just from Victoria but also from states outside Victoria, will benefit from the support that this program offers. I'd like to wish you well for the remainder of what will be a terrific program. I've seen some of the speakers that you've got lined up and I wish I could stay for the whole day. I think the choice that you've made of wellness as the focus of today's conference is such a very important one. All of you in your professional lives give so much, nurses and midwives do. It's a part of the job, and I know for many of you it's part of what brings you to nursing and midwifery. You have a calling to do it. But making sure that we look after you is part of our job as governments. So I wish you all the very best with the rest of the conference.
Just before our speakers leave the stage, I'd just like to present a couple of gifts. Thank you. Thank you very much, Minister. That was amazing. Thank you. For those of you who aren't around the significance of that announcement, it's something that we've been working at the NMHP for a very long time. So today is a very, very important day and landmark day. Our keynote speaker today, who doesn't need an introduction because I'm sure most of you know her, or have heard of her, or have heard her speak, but I will anyway. It gives me great pleasure to welcome Beth Wilson. On the 1st of May 1997, Beth became Victoria's Health Services Commissioner. She's a lawyer by training and has worked mainly in administrative law. Beth has had a long-standing interest in medico-legal and ethical issues. As Health Services Commissioner, it was her role to resolve complaints about health service providers with a view to improving the quality of health services for everybody. Beth had a long and illustrious career where she received several important awards in recognition of her achievements. Beth regularly conducted seminars, lectures and classes for consumers, carers, health services providers and others. She advocates for work-life balance and the importance of humour, which you'll see a lot of today, storytelling and music, which you'll also see today, in providing inspiration and education in health promotion. Beth retired as Victoria's Health Services Commissioner on the 31st of December last year, and she assures me she's as busy now as she ever was. Ladies and gentlemen, please welcome Beth Wilson.
Good morning, everyone. I too would like to acknowledge the traditional custodians of the land that we're meeting on today and pay my respects to their elders, past and present. I'd also like to acknowledge any Indigenous friends who may be in the audience today. And whenever I have the privilege of doing the traditional acknowledgement, it always reminds me to be mindful of and respectful to my own elders. I was interested to hear the Minister being described as a reasonably young mum. I went to the Caltex store the other day and I lost $1. It rolled underneath the counter and there was a big queue forming behind me, so I couldn't get my $1 back. And I said to the lass, "It doesn't matter, it's only $1, forget it." I got my $1 back the next day. I went into the store and there was $1 taped to a note. And the young man gave it to me. He probably shouldn't have, because the note said, "Could you please give this $1 to the elderly lady who comes by every day with 2 dogs?" Are you elderly at 63 or... Oh, she might be right, actually. We don't think of 63 as old in my family because my mother is 93 years of age. She lives at home, she mows the lawn, which is pretty embarrassing, especially when she mows out the front. I said to her, "Mum, do you really think you should still be doing this?" And she said, "What am I supposed to do, sit around and get stiff and sore? You've got to keep moving." And I said, "Well, all right." And I said, "But do you have to do it out the front where all the townsfolk," I'm from Hastings, I can just see all the townsfolk saying, "Oh, well, you look at that poor old woman mowing the lawn. Her daughter's, she was the Health Services Commissioner. You'd think she could afford a mower for her poor old mother." Mum is a very funny lady. They gave me the Member of Australia medal this year, which I wear very proudly for the kids of Hastings. And I had to go on Radio National to receive the medal. So they ring you up first and have a little chat about what you might be talking about on the day. So I told the guy that when I was 11 years of age, my mother was what was known in those days as a deserted wife. We were living in a little weatherboard shack, worrying like mad about money, and she had 5 kids to bring up on her own. And she was going through a list of names in the paper, and all of a sudden she started to hoop and holler, and we all thought, "Gosh, Mum's gone mad. Who's going to look after us now?" And what she'd come across my name as the recipient of a Commonwealth scholarship, and that's what made her so excited. So I said to my brother and to Radio National, "Don't tell Mum that the medal's coming. On Australia Day, go and get the papers, get a big magnifying glass, and let her find it for herself." Because I wanted my mother at 92 to feel the same way she did when I was 11. So Radio National said, "We want to know what she says, we want to know, we want to know." You know what she said? She said, "Oh, that's good, isn't it?" Mothers. I think my mother's over me. However, she does support me. She came to see me a few days later and she said, "I went down the street," she said, "I didn't want to brag, but I said to the girl in the shop, 'Give me a bra 2 sizes bigger than the last one you sold me.'" And the lass said, "Why, Mrs. Wilson, you're shrinking?" She said, "Because me daughter's got the Medal of Australia and me chest sticking out that far." So that's more like the mum that I know. So she needs support. We all need support. I was up at Benalla a couple of weeks back for the inaugural Staff Awards, and it was a fantastic day. It was the same day that I, in fact, got my Member of Australia medal from Government House, so I took that with me. The staff who were getting awards had managed a whole range of achievements. Some of them had just done first aid courses. But one young woman came up, she was being given an award because she'd become a fully registered qualified nurse. She was the cleaning lady at that hospital, and somebody tapped her on the shoulder in management and said, "How would you like to consider becoming a nurse?" So it was really fantastic. The benefits to the community, the benefits to her, the benefits to the hospital. It's just such a win-win situation. But she, like all health professionals, will need ongoing support, and that's why it's so important that we have the NMHP, Nursing and Midwifery Health Program. I was around when we were arguing about having this for years. The doctors had a health program, the nurses didn't. The excuse that was given was, "It's too expensive, there's too many nurses." How can it be too expensive to support our nurses? We can't support our patients if we don't support the nurses and midwives as well. And the themes of this important conference they include the work of the program in supporting nurses and midwives, and we need to consider what the consequences are if we don't support them. When I was the Health Services Commissioner, I saw a few horror stories involving some very poor practices in nursing, generally on the night shift, and I often wondered whether if we'd had some more early intervention, we could have prevented some of these things from happening. So please, if you feel like you're going a bit off the rails, don't be afraid to ask for help. When the doctors started their help program, it was a voluntary program. And can you imagine finally getting the courage to ring up and say, I'm on too much pethidine, or I'm shooting up on fentanyl, only to be told, oh, this is a voluntary program, you can't talk to anyone until Thursday. You're going to lose that opportunity to help a person. So it needs to be a well-funded, well-supported program if it's going to support the nurses and midwives, and that was fantastic to hear what the Minister had to say today. We've come a long way. We're seeing a campaign at the moment about keeping nursing staff safe in our hospitals, and that's a very important program. I would just say, with a note of caution though, bringing in armed guards to our hospitals will not be the solution to the problem and may even make it worse. Nurses need to be protected. If we're going to have security guards in our hospitals, they need to be properly trained about health issues and not just come in, you know, like big thugs to break up an argument. One of the complaints liaison officers in our who helped me when I was Health Services Commissioner said that they had a kind of noisy patient, and she heard this patient being marched out by two big burly security guards. So she went over and talked to her and asked what was wrong, had a quiet little chat, everybody calmed down, it was fine, she could come back and get the health service that she needs. I'd rather hear more talk about keeping everyone safe through good design, proper lighting, having some volunteers around, a cup of tea, a bit of good explanation. These things mustn't be left out. We're living in an age where we hear a bit about austerity and cutbacks. That makes me very nervous. I've seen in my long career a lot of problems that happen when cutbacks occur, and it's usually cutbacks to support and training and education for nursing and midwifery staff that cop it. Our regulatory systems, of which I've been part, we shouldn't have to wait until there's a disaster to happen and then pounce on the poor nurse who is struggling to do the job. We believe in early intervention, in the prevention of disease and health promotion for our patients. It only makes sense that we do that with nurses and midwives as well. We need to understand each other's needs to make people safe to get help when they need it. So I'd just like to say thank you very much to the program and the people who've run it in such a dedicated way. One of the important things in our hospitals is good hygiene control. Hand washing, so important. The infection rate palpably drops when we're aware of good hand hygienes. The other good thing we need is a bloody good laugh together, and maybe even a bit of a sing. That's a really important part of health and wellness. How do you feel about having a sing? Yeah? I've got a bit of a surprise for you today. I've got the one and only, from Things of Stone and Wood, the very talented Justin Brady to help me out with this song. Where are you, Justin? Make him feel welcome. Also helping me out today will be you, because you're going to be our backing singers. You're going to be the disinfectors. And I'm just going to teach you this song, which I'll probably do out of tune until Justin gets all rigged up and can give me a note. Oh, thank you. This is how the chorus is going to go, so listen carefully because you're going to have to sing it. There ain't no bugs, there ain't no bugs, there ain't no bugs on me. There may be bugs on some of you mugs, but there ain't no bugs on me. You reckon you can do that? Okay, after the count of 4. 1, 2, you want to say something, Justin? It ain't working. 1. 1, 2, 3, 4. There ain't no bugs, there ain't no bugs, there ain't no bugs on me. There may be bugs on some of you mugs, but there ain't no bugs on me. I reckon you can do it louder than that. What do you think, Justin?
Whatever you say, Beth.
All right. Let's start with the chorus, everybody.
1, 2, 1, 2, 3, 4.
There ain't no bugs, there ain't no bugs, there ain't no bugs on me. There may be bugs on some of you mugs, but there ain't no bugs on me. 2, 3. Senior nurse didn't give a cuss, said there ain't no bugs on me. I don't give a toss, said I ain't gonna wash, 'cause there ain't no bugs on me. There ain't no bugs, ain't no bugs, ain't no bugs on me. Maybe bugs on some of you mugs, but there ain't no bugs on me. 2, 3, 4. My physician made a big decision, there'd be no bugs on us. We made a pact to clean up our act, no Staph aureus. There ain't no bugs, ain't no bugs, ain't no bugs on me. There may be bugs on some of you mugs, but there ain't no bugs on me. Solo! My surgeon got an urgent to eat a bowl of sturgeon while operating on my knee. Silly old love didn't wear his gloves and he infected me. There ain't no bugs, ain't no bugs, there ain't no bugs on me. Maybe bugs on some of you mugs, but there ain't no bugs on me. 2, 3. I was on the list of an orthodontist and there were no bugs on me. He got pissed, hygiene got missed, and now he's got Hep C. Ain't no bugs, ain't no bugs, ain't no bugs on me. There may be bugs on some of you mugs, but there ain't no bugs on me. Solo, Justin. Professor No Worry in a great big hurry said there ain't no bugs on me. Should have washed his hands before he touched my glands, 'cause now his bugs are in me. There ain't no bugs, there ain't no bugs, there ain't no bugs on me. There may be bugs on some of you mugs, but there ain't no bugs on me. Last time, nice and loud. There ain't no bugs, there ain't no bugs, there ain't no bugs on me. There may be bugs on some of you mugs, but there ain't no bugs on me. Thank you very much, everyone. Thank you, Justin, and I hope that you have a fantastic conference. Delay tactic.
Justin, could you join us as well, please?
Did you hear us?
Not sure. Funny, talented, and intelligent.
And elderly.
Today's message is about wellness and fun and happiness, and we know the research tells us that makes us feel better and improves our health, and I'm sure you've kicked us off to a great start today, Beth, so thank you very much. And on behalf of the organisation and the delegates, I'd like to present you and Justin, if he comes back,
I'll take
gift.
his.
Thank you.
Thank you. Thanks, everybody. Thank you.
Could I ask our panellists to come to the stage, please? I might just mention while we're waiting, the program today is based largely on what you told us from 2010 that you wanted more of. And so we hope that today is going to be a bigger and better model from 2010. So those of you who attended then, I'm sure you'll hear some new messages and some stronger messages and fresher messages, but you'll also hear some new stuff as well. And we've got a very big musical component throughout today too. So we're really excited about the day, and we hope that you have a terrific time as well. You'll see in your booklet, there's a question NMHP, does it make a difference to nurses and midwives' health? If you ask me, you'd probably be very clear about what the answer to that was, but we thought that today we would get some important stakeholders with us today to give their different viewpoints. So about a decade ago, the conversations about what we as a profession could and should be doing to support our colleagues with sensitive health issues started in a very serious way. We've come a very long way since that time, and today I'm very pleased that through the support of the people gathered here on stage, you'll be given an insight into why and how the service commenced, who was involved in making it happen, and what had to be done to establish the first and currently only nurse and midwife specific health service in this country. And we can't find another one just like this anywhere in the world. These four people know the NMHP, each in a slightly different way, wearing a slightly different set of lenses. But each in their own way, they're able to provide their perspective on this unique organisation. So to start our panel discussion entitled The NMHP, Does It Make a Difference to Nurses and Midwives' Health? I'd like to introduce Belinda Morrison. Belinda was a registered nurse with a broad clinical experience for 25 years and led the A&F Vic branch for the majority of her 15 years with that organisation. Today, Belinda is here as the Foundation Chair of our organisation. Belinda, thank you for joining us today, and can you start off by telling us how you got involved? That mic's on.
Start from here.
You can stay or you can come up here, whatever you feel comfortable.
I'm easy.
Thank you, Belinda.
Is it working? I'm going to start with another elderly story. Back in the 80s, when nurse unit managers were called charge nurses, I was a charge nurse in a public hospital, and we had for the sake of the story, I'll call her Susie, one of the senior nurses who was very committed, very dedicated, and she had a problem when her marriage was breaking down. And this was a time when I think those of us who were around then would support me when I say there tended to be a view of nurses that if you couldn't cope, you just should get out. We weren't there to help you get through whatever your problem was. But Susie was a very valued member of the staff and well liked, and she started drinking heavily. And so she came to work, sometimes I'd say pissed, other times I would say just moderately not too good. And so I instructed the staff that when she came to work in that state, we were to make a bed. We had not a linen cupboard but a linen room, and we would make a bed in the linen room and just pop her down where she could sleep it off, sometimes the whole shift, sometimes just part of the shift. And the reason I did that was that my concern was that if I reported her behaviour to the nursing executive, they would feel they had a responsibility to report it to the nurses' board. And the registration board would feel they had a responsibility to deregister her. And so that's why we let her sleep it off in the linen room, because there wasn't much knowledge, and I'm not just talking about nursing executive or charge nurses, there just wasn't much knowledge in the profession about helping each other. And eventually she got better herself and stopped drinking, came back to work. So I've always had that story in the back of my mind whenever I've been thinking about BNMHP. In 2001, the doctors started their program, and it was established by the AMA, which is the Doctors' Union, and the Medical Registration Board. And shortly after that, 2 or 3 years after that, there were a group of nurses that got together, and I'm going to name some, and I'm sure I'll miss some out, and I apologise to those. There was Heather Pickard, who was the first CEO of the program, Lisa Fitzpatrick, Louise Milne-Roche from the Nurses Registration Board, Yvonne Chaperone from A&F, and others. And they got together and set up a committee to see whether or not it would be possible to establish a program like the doctors for nurses. And finally, as a result of these discussions, ANF Vic Branch and the Victorian Nurses Board established a limited company with 2 members, and those 2 bodies were the members of the limited company. They then set about establishing a board, and the board consisted of 2 directors appointed by ANF, 2 directors appointed by the board, and an independent chair. And so there was an office obtained in St Vincent's. The board appointed Heather Pickard as CEO. She then appointed other staff, and the doors opened in 2006. It was interesting because there was not one objection from anybody about setting up this program. In fact, on the contrary, the whole concept was fully supported by employers who were grateful to have somewhere to send staff where they had mental health or addiction problems, drug and alcohol problems. Certainly from nursing executive, there was full support. There was obviously support from ANF, and there was support from nurses themselves. And there was also support from the Health Minister at the time and the Health Ministers since. So when we come to 2013, we look at the fact that the program is well established. I should digress here to say that I think 2 of the important things in the success of the program has been the calibre of the 2 CEOs, firstly Heather and now Glenn. But it is an unqualified success. It has helped hundreds and hundreds of nurses. It has also helped employers. It has helped nursing executive. And it, most importantly of all, it has helped the community, because they can have greater confidence that the nurses that are looking after them are well and have been cared for if they have had problems and are only back working once fully recovered. So as I see it, this program is a win-win for everyone. And I should tell you that I was about to go on and say that given that the funding is only guaranteed by the National Nursing and Midwifery Board until the end of the financial year next year, I was about to say there is a loss-loss. But given Tanya's recent comments, hopefully the health ministers will agree that a national program will be set up and will continue. So it's a nice story, I think. Thank you.
Thanks, Belinda. I think having that knowledge and that history is really important. It's important that it's shared here today and not lost, because that sort of stuff is really vital to the fabric of this organisation. So thank you. I do want to call for questions, but I'd like you to hold on to those until with each of our 4 speakers have spoken, if that's okay. Thank you. I'd now like to introduce Greg Miller. As I said earlier, Greg's a registered nurse, and he's was chair of the Nurses Board of Victoria during the early days, and is now the current chair of the Victorian Board of the National Nursing and Midwifery Board. Greg, it's great to have you here, and I appreciate you're a very, very busy man. You're still working full-time in a nursing capacity as well as your role with the board, and I think that your commitment to this organisation through your roles is strong today in the fact that you've managed to set aside this time in your busy schedule, so I thank you very much. Could I just get your recollections firstly about the early days and your involvement in that, please?
Yeah, sure. Thanks, Glenn. Is this on? It's working? I actually started on the Nursing Board of Victoria in 2006, so much of the hard graft to get this program up had already been done. So when I arrived on the board, I had for many years as a mental health nurse held some reservations about the Nurses Board of Victoria's ability to appropriately regulate me. And finally I sort of got a bit of a nudge in the back that went something like, either put up or shut up. So I applied for membership of the board. And I've got to say, I was humbled by my experiences, having sort of held them in contempt for a fair while, to find that in fact they're an incredibly committed group of people who really and very authentically cared about the profession. So when I arrived in 2006, this deal was just about to be signed, and the tone of the board and the excitement amongst the members at the time, having helped to steward this process through to a conclusion, was really upbeat. And there was a lot of excitement about the opportunity to not just be seen, I guess, as the regulators and the bad guys with the big stick, but also the helpers as well. So that was kind of my experience of it. And then, of course, I've been on the board and had, I guess, had responsibility to work under 3 different pieces of legislation now. So, and each one of those really changed the role of the board in terms of how the board regulates nursing and midwifery, and particularly in the area of conduct, the management of matters notified to the board, and how the board is able to intervene in matters of either conduct or performance or health. And I guess the most relevant of those today are around health and in some cases health combined with conduct matters. So that's where we were then. Now we're pretty busy. I don't know if you want to know what we do now.
Certainly, Greg, that'd be great.
Yeah. I guess, look, in terms of the current board, you'll be aware there's quite a complex governance system now with regard to regulation, and many nurses now see the face of their regulator much more as AHPRA than the boards that AHPRA serve, really. And I think there's a bit of a loss there in terms of the connection between the board itself and nurses and midwives. The state and territory boards, I chair the state board in Victoria. We are, I guess, charged with the operations in Victoria of the Nursing and Midwifery Board of Australia. So the national board sets the rules in accordance with the Act, and we do the state-based grunt work, I suppose. And part of that is managing notifications. In Victoria, we have somewhere in the vicinity of 92,000 nurses and midwives registered. We receive a notification about the conduct, health or performance of a nurse almost precisely, on average, 1 per day. So around 365 cases are notified to the board. Of those, a little over 1 in 4 are directly related to matters of health. And of those, there would be a number that are also related to matters of conduct that are directly caused by the health issues, primarily drug and alcohol related problems. Our role is to keep the public safe. That puts us on the sort of side of the state, if you like. But we also have a tacit and very clear responsibility to take into consideration the welfare of the nurse or midwife involved. And so I guess we spend a fair bit of time and energy. We meet twice a month just to look at notifications and investigations and those outcomes. A subcommittee of 4 of the board, and we put a tremendous amount of energy and effort into considering both sides of those issues. We've been very, very pleased to, from time to time, actually have even Glenn represent or assist a nurse or midwife who has had to come before the board to make a case for their registration, if you like. And I think that says something about the personal touch and the professional approach that the program brings to its work in sponsoring and supporting nurses in when we might require a conversation directly with a nurse or a midwife, and the CEO of the health program comes and sits with them. It gives us much greater confidence, much greater ability to help that nurse return to practice with some undertakings from the nurse that they will continue to participate in the health program and seek other supports. It makes an enormous difference to us, and we've been very, very worried about the future of the program and felt as a state board and effectively a committee of the National Board somewhat impotent to have any major influence over its future. So I was very pleased to hear Minister Plibersek's announcement today. Thanks.
Thanks very much, Greg. I am indeed in a very privileged position I meet everybody in our industry, representatives of every sector in our industry, in nursing and midwifery, and I can certainly attest that the passion and the sincerity that the people that make the decisions about nurses who need support with their health, who've come across the table of the board or APRA, that the people that Greg works with and Greg himself take very, very seriously their responsibility and understand that there is someone behind that name or number, and that the decision that they make will ultimately have an impact on their professional and personal lives. So I think we're in very good hands in Victoria in that respect. Thanks, Greg. Next, I'd like to introduce Lucy Cudahy, who's the Executive Director of Nursing and Midwifery Services at Barwon Health and member of the Metropolitan Health Services Nurse Executive Group. Lucy's joined us here today after she's had a pretty busy couple of months, and I'm grateful that she's taken some time out of her busy day to come up from Geelong. And again, her commitment to the principles of the program are on display here, just the fact that she's been able to join us today. Lucy, can I just ask you to start with, do you recall your first, Lucy's got a slide presentation which we'll be putting up in just a moment, but do you recall your first contact with or first knowledge of the program and what that was?
Yeah, I think that's about slides 5, Glenn.
I might throw to slide 1.
It's absolutely freezing up there, and I just saw someone in the front row put a coat around themselves down there. I remember the early consultation phase, really, and with the Metropolitan Directors of Nursing, and the issues that were important at that time for us, and I think it was about 2005, 2006, were that the establishment of a program that was understood by the profession. So it was important to ensure that the program was staffed by people who understood the pressures of the profession, who understood the nature of the work, and understood the complexities and the risks associated with working in the profession that we do, such as the availability of drugs and the issues associated with that. Privacy was an issue for us. I remember speaking not myself speaking quite strongly, but it being an issue that in fact received a lot of attention. The privacy of the individual and how would that be managed. There was confusion about, when would you refer to this body and when would you refer to the, as it was, the NBV at that stage. And indeed, because this was going to be possibly a new and an important step, in fact, when did we talk, or when did we notify the board, or when would we be working with the Nursing Midwifery Health Program, and how would this all come together? So there was, some concerns for us around all of that we wanted discussed. Communication, we absolutely didn't want to lose our staff into some other space, and so there was an essential that there was good communication. I remember that well. We wanted to understand what was the counselling and treatment program going to be like, what indeed were you going to do. But importantly, I do remember that there was, it was seen to be that there would be a connection to a safe place for us to refer an employee, and that we wanted that to be recognised, because at all points the executive directors want to retain the nurses and midwives. and we recognise our dual responsibility in ensuring that the patients receive the best care that they receive, but also that the nurses and midwives are supported in the work that they do. So that was the nature of, as I recall, those preliminary conversations.
Excellent. You might want to talk a little bit about if you could just give us a bit of a scope about where you work and how that's unique, like your geographical region and things.
I'm currently employed as the Executive Director of Nursing and Midwifery at Bowen Health. Bowen Health is located in Geelong, and though we're in the paper today, in terms of the closure of Ford, you need to know that Geelong is alive and well and very healthy, and even if Shell does go, and even if Alcoa leave, indeed, many people are opting to come to the region, and in fact it's the fastest growing region in Victoria. There are about 6,000 employees that we employ. We're the largest regional employer, and of course Geelong's situated at the top end of the Bowen Southwest region. Of our 6,000 employees, around about 43% are in fact nurses, and that would be typical of most health services. We operate as a metropolitan health service, but we provide tertiary-led services across the region. Probably in terms of our profile within the region, there are pockets of socio-economic disadvantage associated with higher health risk factors of intergenerational poverty, poor academic outcomes in many parts of Geelong, but in fact, on the other side of that, Deakin University and the Gordon TAFE and many of the other TAFEs are in fact an important building block for the future of Geelong. There's a very strong family culture in Geelong too, coming from Melbourne and working now in Geelong. That's what I observe, is the nature of the community and how strong it is. Just in terms of Geelong itself, one of the things I've been at Geelong now for 8 years, and over that period of time I've been looking at the demographics and what's changed, and though it's changed in our health service, it will be pretty similar in most of the metropolitan health services as well. In terms of the average age, our average age is 43.8 years in December last year. Of the nurses who are greater than 50 years, of which I'm one, the 34% of the overall workforce, and that's about 2,500 nurses, have an age that is beyond 50 years. Of the nurses who are less than 40, that's decreased by 13%. I now have about 190 nurses who have an age of greater than 60 years, and in fact I'm 60, so I'm in that group too. So the demographics are changing, and thus the health issues are changing, and that's what I'm finding as the Director of Nursing. I'm seeing a different set of problems when they come to issues that I might refer on to the board.
The ageing population is a thing that we notice a lot at our organisation. We meet a lot of nurses who have, as I said in the introduction, sacrificed many other things to do the job that they're paid to do. What sorts of, when you're confronted by those older nurses that you're talking about, Lucy, what sorts of things are they saying to you are causing them the distress and anxiety?
So if I look to the nurses, I would refer to you, to that cohort?
Yep, they're good, yeah.
Okay, so that would be in the area, in the main, of alcohol use, I suppose, more so than mental health problems. We have a strong mental health program, and so from where I have referred, or the health service has referred, it's the issue of substance use. And as the nurse said to me last week, she's returning to work, having been away and been working with the Nursing and Midwifery Health Program now for just a little over 12 months. She said, Lucy, to put me back into that place would be like putting a kid back into a candy store. So you need to think about the return to work, as well as the place that someone will work if indeed they're in a period of rehabilitation, but in fact the drugs are part and parcel of everyday work. So working with the program and also then with other managers around where, and the individual clearly, about where their return to work could be, so that they can meet their goals.
You're also wearing another hat today as a representative of the Metropolitan Directors of Nursing Group. Has there been any trends or any concerns that you and your colleagues have experienced or noticed over the last little while in relation to nurses' health that's come to your attention that would maybe needs to be addressed in some way?
I'm not sure exactly what you're alluding to, Glenn. I'm not aware of any new trends. I think that we would all be seeing, there are greater pressures in the workplace. There's no debate about that. And there certainly are for, executives also. It is a microcosm of the financial changes that are happening, generally within the economy, both in this nation and in others. And so certainly we're seeing that, and more people being prepared to talk about that. So that would be something that I don't believe I might have had conversations with people previously about, that I am intending to have some conversations about. But with the implementation of this service model, though Belinda said it was well accepted, and certainly at a senior level I think it was, I was quite clear we needed to sell the concept to the greater workforce, so that they understood that in fact we would be working with another organisation rather than handing on our staff member to someone else, if you like, that we would continue to maintain a relationship with the individual, work with the program, but also make sure at the same time we were working with, if it was an issue of drugs in the workplace, then in fact, or behaviours that were of great concern, that we were at the same time working with the NMBA as it is today. So there was a need for us to provide some leadership around that and make sure that we had our leadership teams talking about it, and that we had the relevant literature out there so that it was out there in every workplace. And so that was an important step, I think, in those early days of making sure that it was quite well understood.
Thank you very much. Is there anything further you'd like to add before?
Well, I was going to just rip through the benefits of the program. So it's interesting. I worked with a couple of directors of nursing to talk about what we thought the benefits of the program are. And I think it is clear for us that the program works with both the employee and the employer. We are initially, once we refer, we're initially consulted on our expectations, so the organisation expectations for the individual that program will be working with. In fact, the program supports all of, I think, health services policies on substance use. So if you go to the policy, just Google substance use at your workplace, then you'll find, in fact, this is a very good fit with it. It's terrific, actually. I think it reduces the risks in the workplace and individual risk posed by the use of alcohol or other drugs, and I've personally found that. It addresses workplace factors that contribute to mental health or substance use. Again, I've had experience through phone calls with the staff around, exactly that matter. And as Greg said, it prepares the employee for the APRA review or the NMBA review. And in fact, you guys have got an excellent reputation. And my personal view is that it's a challenging journey for the employer and the employee. I'm a very strong advocate of the model, which is obviously why I'm up here. And the experience of working with the counsellors is that they communicate with us extremely well. It takes a huge commitment from the individual who joins the program, but from you and from us to ensure that we can get the person back into the workplace. It's unrealistic to think that you'll have a 100% success rate. And in fact, that's been something I've learned. And I think the program absolutely has lived up to the expectations that were outlined, and that is, accessible, timely, supportive, practical, compassionate to both employees and individuals. So, well done.
Thank you very much, Lucy. About 3 years ago, it was longer than that, but Belinda and I embarked on a very rigorous campaign to let everyone around the country know about this program. And one of the things that we knew we needed to do was to prove that what we knew worked, and have that documented and written and be out there in the public domain and to be scrutinised. And one of the people that we were fortunate enough to meet along the way was Dr. Bridget Hamilton, who's also a registered nurse. And Bridget is a senior lecturer and coordinator of research training in the Department of Nursing at the University of Melbourne. And Bridget was the person that we initially engaged to embark on the research over 2.5 years ago now. I must note that the project, which was funded through the NBV, the Nurses Board of Victoria at the time, so we were very grateful for that. Bridget, thanks for coming along today. Can you just give us, firstly, your recollections of what took place when we first talked about this program?
Sure. Well, Glenn, your panel is about does NMHP make a difference? And the invitation or the opportunity that was placed before myself and then Dr. Rachel Duncan with me was to look dispassionately at the facts, at the data around the program. And so in some ways, my interest is in what does a dispassionate and impartial eye have to say about a piece of work that, lots of people in this room and of course on this panel have quite clear views about and commitments to. So it was an opportunity to, as people who were relatively unfamiliar with the facts of the program, knew about it as a registered nurse, about its existence and not a lot more than that, to engage in a really substantial piece of evaluation work. And that was made possible through funds from the Nurses Board of Victoria, and I think the idea of an externally conducted commission piece of research was a terrific idea, and it was an idea that came at the right time for the organisation in terms of it having 5 years of operation, being quite a mature program, and it really warranted some evaluation, and that's quite aside from some of the politics that were probably informing that as well. So we were really interested in a piece of evaluation about what appeared to us to be a fairly special and unique program. So, so we took up the contract to do that work.
How did it, can you just briefly sort of talk about the process that you underwent and how it fell out?
In terms of the method that we employed, we decided to conduct a multi-phase mixed method study. So the study that we undertook was under the umbrella of program evaluation and program logic program evaluation. So the first thing we did was spend time with the key stakeholders of this organisation, looking at what they thought they did and having a look at their documents about what they intended to do, and from that bringing together an understanding. And I think probably it was the first contribution that the evaluation made, was to be able to feed back to the board and to the staff our understanding of what was actually the intention that you had behind the program, and to reframe that. So it was clear to us, having looked at the various sources and talking to the various stakeholders, that there was more than just a direct provision of service to nurses and midwives. That is clearly the key aim of the service, the program, to provide that service. But there were really 3 elements that came through quite strongly. One was the issue of providing direct referral support and particularly casework with nurses and midwives, but not equally but significantly, a health promotion aspect of the program was quite prominent in the work that you did and the evidence that we could look at. And so that was an interesting thing to bring forward, and to look at where does health promotion fit in the remit of this program, and what is that as an independent or an additional arm. And then also that there was a really strong investment in the governance of the organisation, and some quite unique features compared to, what are probably not very comparable services in the States in particular, and a little bit in England. So we were also needing to dig up the background around why the program had been established, and to look at the evidence at the time of its inception. And it was quite clear from the work of Callie Berryman, who's a researcher and a drug and alcohol nurse, that there's quite a significant problem both of substance use and distress around substance use, and work-related stress aligned to substance use, that was absolutely stigmatised amongst nurses, and that it was a very difficult thing for people to come forward and seek help. And that wasn't an Australian phenomenon only, but her PhD research was in that area. So stigma is a really significant barrier to people being assisted. Similarly, there's policy trends around services being provided in a generic way, and that's a worldwide trend, that health organisations, like every other employer, might provide support to people, and how might that work, and in what ways might that not work necessarily for specific workforces. And we looked long and hard to find sister services or peers for this organisation, and we did discover that there were some interesting models described as alternative to discipline programs in the States particularly, and that those organisations were already aware of the Nurses and Midwives Health Program. So that background work, that understanding of the program took us to the next step. The next part of our evaluation was having access, seeking ethics approval to have access to the case information about the work that the centre, that the program does, and we were able to access the summary data of all the referrals, of the nature of the range of contacts, the breadth of service provided, to be able to characterise that, and also the outcomes in terms of work and satisfaction. So those were the things that we were able to look at specifically about casework, and also to sum up that program health promotion component. So those were the methods that we employed. There was a lot of qualitative data, survey data, and we undertook focus groups with the referrers, that is employers and regulators, and also with nurses themselves who'd been participants in the program to find out their experience of the program.
Thanks, Bridget. You talked about your dispassionate approach, which I know you have to have, but
Yes,
you were
that's my
struck.
job.
You were struck by some things, though. Can you talk about those?
Oh, look, I mean, data's data and it tells a story. And we were absolutely struck in the very first phase. We looked at the 100 or so surveys that people had returned each year around their experience of the program. And I had a quote listed there, but I can probably almost remember, nurses saying it was so refreshing to be supported as a nurse by a nurse who understood my situation. And I think there was some phrases, very, very extreme sort of comments like, thank you so much for resurrecting my career. I was at my lowest ebb possible, and these people showed me respect, and the fact that they were nurses made all the difference. So there were quotes of that nature in that survey data, and that was fairly compelling and also almost universal. So it was very difficult to find negative comments in people's feedback, which is relatively unusual in a survey of that kind. But there were other things that were telling in the numbers as well, and so we wanted to look at that mix of the spread of work that the program does, so we were able to pull together the information, and I'm trying to pick the eyes out of 60 pages for your benefit today. For instance, it was quite evident that the program served the nursing and midwifery community broadly, in that there was a gender mix, a mix of just over 20% or just under 20% of the referrals were men, and over 80% were women, as we might expect. That there were a mix of rural and metropolitan nurses, so approximately 25% of referrals were from the rural service and 75% from metropolitan areas, from every area of nursing, and registered nurses of different divisions. And also it was interesting that this issue of being, the program was perhaps promoted as a service primarily for people with substance use problems, but increasingly over its 5 years of operation, more than half of the referrals were people self-referring with issues of stress and mental health problems, depression and anxiety, and that those, in keeping with the wider community, were becoming less stigmatised problems for people to come forward with. So overall, the program that provides as much support to people with a primary problem of mental health issue, and as they do for people with drug and alcohol problems. And of course those two things are related, so it's a somewhat artificial distinction to make. Nevertheless, it's an important distinction because it also means the staff group, you have a combination of people with drug and alcohol expertise and mental health treatment expertise, and that's important. And the other thing inside the casework piece of work, which is the larger commitment of your staff time, was that some of that work is very intensive, and we did focus on that to look at the outcomes for that group of people. So out of 600 plus referrals in the time period, we looked at 150 or so of those it was more than that, about a third, 180 of those were engaged in very intensive work of quite a diverse kind. So the combination of individual counselling, but also attending to groups, and a great deal of the advocacy that Greg touched on, the idea of you attending, or members of the program attending meetings at the board and negotiating and working very closely with employers. That kind of work rather distinguished the program. There really isn't a lot of evidence in the international literature for an equivalent comprehensive program of that kind, and it's not surprising that the results for work return were better for that group even. So, you know, it depends on the way that we define that, and we could probably do better at defining that, but well above 70% of people who had an intensive piece of work because they needed it and their situation warranted that, also were able to return to work. So that was a really impressive aspect of the program, and something that we thought was worth highlighting as a distinctive feature.
Thanks, Bridget. I know that you and I could talk about this all day. We're limited by time. The report can be viewed, it's on our website, so the details are available around the place. Thank you very much to each of you for your contribution today. I'd like to invite you to ask questions of the panel, if you would like to. There's microphones around the place. And I think we've got one. No, we don't. False alarm. I might just raise your hand when you get to a microphone. I might just acknowledge that statistically, another false alarm. Statistically, every one of us in this room has issues, and myself included. And every one of us is going to need some support at some stage in their lives. And most of us have got the resilience that is required to be able to work through challenges in our lives with the support of our friends and our family and possibly some professional supports. But sometimes we do need to call in some help, which may feel uncomfortable, it may feel threatening, it may cause shame, embarrassment, fear. But I can attest to the responses that, particularly that Bridget's spoken about today and that we hear most days, if not every day, is that I wish I had known that this organisation was around 6 months ago. I wish I had known this wasn't going to be quite so bad. I wish I had known that I was able to come and speak to somebody in an official yet informal and confidential way. I wish I had known that there was a solution to this problem. And interestingly, it's not uncommon for us we're very privileged to hear a lot of information and a lot of people's life stories. And interestingly, we're able to then sort of track that in our own way, and we can identify trends and things and common statements and the like. And you'll note on our cards that there's the cards that are at our desk. They're actual quotes from participants who we've worked closely with over the time, and they're really basic things like, I've just lost my spark, I thought I was the only one who had this problem, and those sorts of things, those sorts of themes. So as long as you're standing and as long as you're breathing and as long as you're in this industry, you're susceptible. And I'd encourage you all to just reach out and ask for that support. It doesn't have to be with us, but ask for support when required. And I think, thank you, you've just saved me. You're going to ask a question?
I'm a nurse who's actually older than everyone who's disclosed their age today, and I'm still working and intending to. What I'm interested in is I heard about this program through, just reading a journal. I don't really know, right? But the thing that I thought was that it was for people who had substance abuse problems, and in my lengthy experience, such as Belinda was speaking of, people who get to that point tend to be very ashamed and also not necessarily able to identify themselves as having a problem, as they may have earlier on. What I'm interested in, though, is the mental health issues, of which there is enormous stigma. And in fact, what we're talking about is anxiety, depression, and I think, nursing parlance, burnout. And as someone who's experienced burnout about 12 years ago and went through a really significant anxiety, depression episode, this wasn't around then, but I do think that we need to work out how to market this organisation for that group of nurses. I think that nurses need to be able to self-refer, or perhaps their friends help them to refer themselves when they are getting into strife, before perhaps they are getting drunk and coming to work drunk, or whatever else, however else their issue may manifest themselves, whether it's eating, drinking, I don't know, just sitting at home doing nothing. And I'm very interested in what the panel thinks about that issue of marketing, because I work in an organisation that's very good, and they have an employee assistance program, and you get 4 episodes, you know, go to someone, psychologist, for 4 times, and then, you know, if you want to keep going, you kind of fund yourself, basically. Nobody talks about this program as being a way of supporting the nurses. So I'm just interested in people's comments about that.
I think Bridget's probably maybe the best person to start.
The first thing to say is that 90% of the referrals are self-referrals, so it is on 2 levels that's very significant. One is that it does suggest people are recognising a problem for themselves, and one would hope that also means acting earlier, both of which are enormously important in this area. But probably, from my point of view of reading the literature and thinking about stigma, it's also quite significant for saying how acceptable the service is to nurses. There's also a small but significant group of people who re-refer, which also speaks very loudly of the acceptability of the service. So it's not really about promotion, but just putting in context the issue of the fact that self-referral and early intervention is absolutely a focus of the program and is reflected in what the program now does. But there are tens of thousands of nurses, it's true, and there's likely to be an unreached group, and I'm interested in what other people think about that.
Look, I'd concur with that. The board, for example, you know, we intersect with nurses with health problems far too late. If we're talking to them or we're receiving notifications, it means that the problem has got to a point where it's significantly impacting their work, and almost invariably it's the employer who notifies that nurse, and that means the employer is worried so much about this nurse's practice that they are no longer safe. That is far too late. I mean, I think the less we see of nurses, the better. The less work I have to do, far better. And that's about intervention and you know, early intervention and promotion. But I understand it's very difficult to promote programs. I mean, I'd wager there's still nurses out there who haven't remembered that they need to re-register in the next few days. See, yes, you're looking ashamed. But that does happen. So it's very hard to keep. There's lots of messages nurses and midwives have to respond to, and it's very hard to promote, I understand.
In terms of marketing, I'd like to make a comment, and that is that when we first started, Glenn visited every possible peak body, every public hospital, etc. I would like to put it on you guys that you assist with the marketing, that when you go back to your workplaces, you talk about it. I'm sure Glenn's still available to come and talk to workplaces or NUMS meetings or whatever, wherever, however. And also you can contact the organisation, they'll send you out leaflets and flyers and everything. But it would be fantastic, I think, if you could all help with the marketing, because word of mouth's the best bit of marketing of anything.
Thanks very much. This is probably a really timely place to end.
Can I just add one thing?
Sure.
Except for Lucy.
Yeah. the bit that I was going to add is, you know, I'm often surprised by teams and workplaces actually know what's going on. And so they're the ones who, in fact, you know, where I'm making a referral, it's late. But in fact, I do have lots of conversation with, you know, either nurse unit managers or even, you know, lower than that, in terms of people being concerned about someone within their team that they're just not sure about and that they don't want to stigmatise as well. So those conversations I know occur in the workplace all the time, but it is making sure that, in fact, we've got the right links in, and when are people, the individual, when are they ready to participate?
Absolutely. And if in doubt, just give us a call and have a confidential conversation. really quickly, we need to break. Thank you.
Very quickly, thank you. I just would like to ask, I'm a nurse, I've been a nurse for 30 years, and recently in the last few years I'm crossing over to a new career, which is really about helping people in their workplace, and women especially who are nurses and busy mums and stretched and under the pump at work as well as at home, find a life balance that supports them to continue the work that they do. And how much does the panel and does the company offer opportunity for those sorts of preventative measures so that we can find processes and techniques that do help us find ease and comfort and flow while we work in this profession that is just draining and exhausting, and I'd love to see that, and I'm a big advocate for that sort of work, and it's my passion, and I really do stand here believing that, you know, I could have left nursing all those years ago and I kept coming back because I actually really did love it from day one. And if I can help anyone, or there are other individual companies out there who have the ability to step in and offer those sorts of programs, is that something that you look at? Is that something that's in the pipeline?
That's certainly the sort of messages that we give people every day. It's practical support, practical advice. I'd love to talk to you at some stage. Please take one of our cards and give me a call.
Okay,
thank you very much. On behalf of the board and the organisation and you here today, I'd like to thank each of our panellists very much for your time, your commitment, your passion and your ongoing support for the program. It's vital. It's vital that you've attended today. It's vital that you continue to talk about this program. So thank you very much. Before you go, just reminding those people who haven't registered to go to the desk and please register. We'll be returning, if you could return promptly by 10:55. And I'm just going to give out a few more gifts. Thank you very much.